So welcome to this first plenary session. The title is The Health System's Contribution to Sustainable Development, Recapping Co-Benefits. And I'm very happy to leave the floor to the facilitator of this session, Dr. Matthias Bismar, Program Manager of the European Observatory on Health Systems and Policies. Matthias, the floor is yours.
Americo, thank you so much for introducing this session, and the session's title is The Health System Contribution to Sustainable Development, Reaping Co-Benefits. And we all know health systems make huge contribution to population health, to the health of individual, to the well-being, and we all appreciate health systems for this. But actually, we also know that health systems make big contribution to other sectors. And we have all seen this during COVID-19, where it was clear, it's not whether we have either a healthy society or an economically thriving society. It goes together, they belong together. And this is actually the theme of our plenary. And Americo, I think, here at the Graduate School of Health Economics, we are best placed to discuss it because your work is always at the intersection between health systems and the economy, and very often the wider economy, actually. And I think this is the things we want to explore today. And it's not only about this economic argument, it's about investment, We want to justify investment in health and health systems, and if we make a big contribution to other sectors, we want to put this on the table and make this contribution very clear. So, health and health systems can make a very powerful contribution to other sectors. Just think about greening healthcare. Sustainable Development Goal number 13 on climate, we have a huge carbon footprint, health systems, a huge carbon footprint. If we green this, it's very cool for the other sectors, actually. Or think about financial protection, poverty, SDG number 1. We have so many countries where people are still suffering from catastrophic household costs because of co-payments. If we fix these co-payment rules, we can make a contribution to less poverty. And of course, health systems promoting gender equality. We will have here somebody telling us a story about this because we all know health and health systems is very much a profession in which the majority is actually women, so very, very important. So I could go on like this, but I don't because we have a fantastic keynote speakers and we have great panelists. And we are today really not so much focusing on the health impacts, but on what we call the co-benefits. And the co-benefits are those benefits which materialize in the other sectors. And we will hear quite a lot about it from our keynote speaker, Scott. But just wait a second, Scott, because I will just announce a little bit the program. We will have a brief keynote. Scott will talk 15 minutes about the concepts, give us a little bit of an overview, the panorama, the nuts and bolts to understand the whole discussion. And then we have a fantastic, fantastic panel. I will introduce the panelists later on. We will go in 2 rounds talking about the intervention, for co-benefits and then the implementation. And then the floor is all yours. We want to take your questions and answers and feed them back to the panelists, so that we can clarify a little bit and take the discussion further. And then at the end, Americo, I would like to ask you to have a couple of closing remarks to conclude the session. So thank you so much. And Scott, the floor is all yours. 15 minutes.
Thank you very much. It is an honor to be with you and to get to talk about this very, very interesting and important, and I hope somewhat provocative topic. What we're going to talk about is how we can have something that we call health for all policies. A health that cannot just contribute to health, that cannot just contribute to SDG 3 in the jargon of the United Nations, that's the Good Health Goal, but health care systems and health systems that can actually do all the things we say everybody else ought to do, like ensure a sustainable planet. Let me elaborate. These are the Sustainable Development Goals. Some of you might know them very well. There will be a quiz as to what color maps onto what number maps onto what goal. There's no prize. Some of them will know them very well. There's a little circular version of the SDG logo on a pin, and if you see somebody wearing it, you know with absolute confidence they work for the United Nations, because nobody else would dream of wearing it. And some of you undoubtedly have almost no idea what these are. Well, what they are is 17 objectives, high-level objectives, goals, broken down into a whole lot of subordinate goals, which are then broken down into indicators which are monitored worldwide. So, for example, the gender equality goal includes the physical safety of women, which then includes specific things such as the safety of public spaces and parks. Right? So it's very granular. Now, some of you who have heard too much about the Sustainable Development Goals or spent too much time around governments are already thinking that this is going to be nonsense, this is going to be hot air. But if you look at them, they are fundamentally pretty much all the things we're trying to achieve in the world. Even if you don't want to call decent work and economic growth by the title SDG 8, it's still something people want. Even if you aren't interested in SDG 2, you're probably not interested in people dying of hunger. So we speak in the language of SDGs because these really are, miraculously, as chosen by our governments, goals that we all want to attain. So those are the SDGs. I can give you an abbreviated summary of how we were doing before the pandemic, which was slow, unsatisfyingly slow, but consistent progress around the world toward pretty much all of the goals. Since then, it's been bad. We went backward on a number of indicators. We went backward on poverty. We went backward on everything to do with inequality. Racial inequality, ethnic inequality, income inequality, gender inequality was an absolute catastrophe for several years during the pandemic. So the latest SDG reports are very, very unpleasant reading because we went backward on things where we weren't doing well enough. And some of these, such as income inequality and gender inequality, it's easy to project that it'll take us 10 or 20 years to get back to where we were in 2019. Bad situation. But at the same time, the pandemic showed us so much about the power and possibilities of working together. Whole of government was another one of these strange phrases that people in certain UN circles use and nobody else really spoke about until we all experienced whole of government responses. It was astonishing in so many ways. We all lived through extraordinary changes in how public administration and health policy and other policy areas operate. The United States had a European welfare system for about 9 months. It was surreal. So on one hand, we've learned how much we can do. And on the other hand, we've also realized that we've created a very, very big set of social problems. This is where a little bit of new thinking comes in, we'd like to argue. And the argument is one that I hope is obvious once you see it, but it certainly took us a long time to see it. It's focused on co-benefits, which is a phrase taken from the climate change literature, because they have the problem, one that we understand, of saying, do something because it's good for the planet, and somebody else says, yes, but it's bad for my income. And the focus on co-benefits is ways to identify win-win solutions, ways to find a policy that is good for health, but also good for something else. Because if you work in any area of health, you constantly find us saying, do this because it's good for your health. Eat better because it's good for your health. And somebody else says, I am poor, I am time poor, I don't need cooking lessons. Right? We say, do this because it's good for your health. Somebody says, I work in a service sector job late at night on the other side of the city. No, I'm not going to walk to work. Over and over again, right? Co-benefits is a way to get out of that. Co-benefits is how to go back and say, how can we find something where we both win? So looking at the impact of health on other good human things, which are tallied in the SDGs, we found there's really two kinds of co-benefits. One is the co-benefits of your health status. One is the co-benefits of whether you are strong and healthy, you don't have impairments in your ability to live and work as you choose. This improves all sorts of things. As we all know, healthier people in many ways are more capable of enjoying and contributing to life. That's why we're here. So, for example, education, we know that educational outcomes are improved by better health. Inequalities in the workplace are often driven by inequalities in underlying health status. If, for example, you don't discriminate against disabled people in the workplace, they're much more likely to get good jobs that give them wage parity. So health status is good for you. You're more likely to be able to get a good job. You're more likely to be able to get a good education. You're more likely to be able to succeed in the economy and in life. Likewise, reducing health inequalities can help us reduce broader inequalities. If you require a wheelchair, building safer cities is going to be able to improve your ability to fundamentally get to work and do your job. So that's health status. We like that argument, right? We like to say that healthier people will be better for the economy and for everything else. Our governments certainly want healthier people because they otherwise think that they're going to go bankrupt paying for pensions. But then there's something else. There's health policy. That's another causal chain, and that's what I'm going to focus on, and our panel is going to focus on. Because we are enormous sectors. Healthcare is a huge and constantly growing sector of every major economy. Only very poor countries have small healthcare sectors. Think about it. Look at this. Look at the infrastructure. Look at the buildings. Look at the energy. Look at the chemicals we consume, the food we serve, the people that we hire. We're huge employers. We're huge spenders. We're huge users of infrastructure. We have a lot of opportunities to do things for sustainable healthcare infrastructure, for egalitarian healthcare employment, for contributing to the strength of cities that we locate our facilities in, for contributing to the education of the many, many poorly paid workers we don't talk about. We have a lot of opportunities because we are custodians of about 8 to 15% of any given major economy. Now, we have a moment here for those of you who are thinking this sounds like health in all policies. Health in all policies, crudely, is us realizing how many of the problems that enter healthcare facilities enter because somebody else didn't do their job. The people who are injured in road traffic deaths because of bad highway engineering and bad transit options, well, they show up when their bodies are broken. We'd like the transportation people to go and fix it. The children who enter adulthood in a bad state of health, and we politely ask the schools to do something about that. Health in all policies is an almost evangelical project of the health sector to go forth and ask other people to address the social determinants of health so that we don't have to do it, because, as we have learned, we're pretty bad at it. But health for all policies goes beyond that. Instead of evangelizing transportation engineers in schools to add our problems to their problems, health for all policies is to say maybe we're creating their problems. Maybe we should use some of the power that we have in health systems and policies, not just to do our jobs, but to help them do their jobs. Because we all know that we've been telling them how to do their jobs for our benefit for quite a while now. How to illustrate this? We commissioned this graphic, which I hope is readable. It's the good hospital and the bad hospital. Let's think about a wonderful present. You get to commission and build a new hospital facility. And you are going to use it to deliver high-quality, financially sustainable, patient-centric care. Let's go. First of all, we need land. Where do you find greenfield land with no pollutants and no existing buildings and no existing people? Well, you find it out on the edge of the city. So we buy ourselves a large plot of land, and perhaps we can sculpt it with some greenery. We can even build a LEED certified green building. Oh dear, there's not even a bus line. Perhaps we shall create a bus line, and we shall hope that the transit people will use the bus line not just to match the times when the patients need to come, but when the employees need to come. Look what we're doing as I tell the story. Then we want to build the best possible building. And it turns out that if you go to contractors and you say, I want a strong and durable building that will be flexible for future developments in technology and patient care, and also a comforting and warm environment, you forgot to mention sustainability. You forgot to mention the likelihood that your building will be an oven in times of climate change. You forgot to mention the really impressive contribution of the healthcare sector to the carbon footprint of all of the carbon footprint of every major economy. Then we need to staff our hospital. We've already stacked the deck by putting it out in the middle of nowhere on the end of a bus instead of a neighborhood where many of the people with mobility or income challenges actually live. We've already created a hospital for people with cars, or people who will not stay with the system because they have to get on a bus at 4 o'clock in the morning if there is a bus. Then, we all talk about hiring doctors, and we all talk about hiring nurses, but in many countries, the real crisis is in the low-paid workforce. Well, I'm interested in delivering high-end medical treatment, so I'm going to go to Serco or whatever other outside company in order to find precarious, temporary people, many of them probably documented, but also probably the victims of multiple inequalities. And they're going to be working not for the health system, but for a contractor where they have effectively no chance of upward mobility and no chance of serious labor representation. My beautiful hospital, it has art in the foyer. It has patient ambassadors. It has lovely technology. The doctors are happy. But look what I've done. The SDG on urbanism? No, I'm creating urban sprawl. The SDG on sustainability? I've put an unsustainable building out in the middle of nowhere surrounded by baking hot parking lots. The SDG on gender equality, the SDG on all other forms of equality, look what I've done to the workforce, especially the low-paid workforce that aren't going to get any upward mobility out of working for the contractor that I hire to clean my hospital at 3 o'clock in the morning. I've done my job. And I've made a whole lot of other people's lives worse. And I've foregone the opportunity to use the health system to do something that we say we all want to do, which is to make people's lives better. We constantly call on other sectors. That's health in all policy. We constantly call on these other sectors for reminder that the transportation engineers should make sure that you can walk places, 15-minute cities. When we build a big new high-tech hospital, how often are we thinking about urbanism and the effect on the urban environment of what we do? We all agree that climate change is already a health disaster. I am not eager for the reintroduction of malaria to southern Italy, but we know it's either here or it's coming. We all know that climate change is a terrible problem. Anybody who had the pleasure of being in England last year will know. I remember being at Heathrow Airport, oh, the irony, looking at the huge plumes of black smoke ringing the airport because England isn't built for 43-degree heat waves. What do you think forget about the heat stroke. What do you think that heat, all those burning buildings did to the respiratory health of Londoners, which is pretty bad to start with? So we've been asking other people to solve our problems. Well, what are we doing to make sure England doesn't burn and Italy doesn't get malaria? Well, you don't necessarily get to build a new hospital. You can do a lot to retrofit the hospitals. In the policy brief that we're circulating at the Observatory publications desk, we actually have examples of hospital in Catalonia, which is just about the ugliest, nastiest, ex-urban piece of Spanish architecture you're going to see. And if you've been to a Spanish far suburban public sector facility, you know that's pretty heavy. And they're retrofitting it to become carbon neutral. And they're thinking, and the doctors get interested in this, about all the ways that they can rethink, for example, the way they run their laundry or the way they sanitize equipment in order to have more of a circular economy, a greener hospital. And at the same time, they're thinking about research, which as a professor, I think everybody should always think about research. And they're also thinking about their workforce and how they can have a more stable workforce with fewer inequalities, less exploitation, and dare I say it, even a chance of upward mobility. So, if you liked this, we're publishing. As I said, I'm a professor. So we have a free article in The Lancet that you can read, free policy brief you can download or get at the Observatory Publications desk, and lots more. I'm very excited about the book coming out with Cambridge University Press, which is SDG by SDG, how health systems and policies, better hospitals, better payment systems, how we can affect these things that we know affect health. And Luigi Siciliani of York University is going to have a special issue on the econometric problems of health status, how healthier people are good for it. So by the end of the year, we hope to have mapped out not just the case for investing in health, healthcare, and health status as a way to a better world that we all want, but also the case that health systems and policies really need to step up. Thank you.
Scott, thank you so much for this excellent overview, and it was really inspirational, but not only inspirational, because I think it was concrete enough to make all the complexities, but also the trade-off between the different options quite clear. And I saw many people, in the audience looking at, yeah, we know all this. It's quite tricky actually in the end. So great. This is the policy brief Scott was talking about. So I think we still have a couple of copies at our book stand. So thank you so much. Please join the plenary. And we are going now into our plenary discussion. And I would like to start with you, Sandra. And we all know you're not only the EHMA president, but you are a healthcare, if not a hospital person from tip to toe. You have lots of experience in this on all issues, from planning to teaching to practicing. And Scott was making the example of the hospital, and we all know that hospitals have very fast metabolism, it's unbelievable, and think about all the waste they can produce, all the wastewater, the carbon and stuff like this. And one of the things which are close to your heart, as I understand, is the circular economy, isn't it? Tell us a little bit about the circular economy in hospitals.
Okay, so first of all, before I start on the circular economy, do we all know in this room, the people in this room, that the health sector has a carbon footprint globally of 4.4%? And although it looks not massive, it's still very significant, and we can do a lot. So the solution is that we need everybody on board to move away from the linear economy model of production, using resources and depleting resources, and not taking any notice of at all the environment. So the solution is circular economy, which is a concept that, of course, needs to be ingrained more and more from people who are taking care of the hospital buildings, but also to the frontliner. Because many times we read the news that the hospital is changing its heating, ventilation, and air conditioning. But hey, I think you actually said that the pandemic, instead of actually helping us to think better in terms of circular economy, we went into crisis management mode, not into systems thinking. So the circular economy is telling us the 3 R's: reuse, recycle, and reduce. So basically, here we need to have everybody on board. During the pandemic, we're focused on getting infection control, but then we didn't give any notice to where we were throwing our masks, the PPEs, all the waste that the pandemic was producing. And I think that is just one example where we were, just focused on the crisis and missing the whole system.
I'm curious to hear more about this in the second round on the implementation, how you changed this, but also very important to know that COVID-19 and the responses to it have been quite disruptive, and we were producing more waste actually at this very moment. Coming to the other end of the panel, I'm coming to you, Thierry Byrne. You're representing the Norwegian nurses actually, and we know that the health workforce is huge. It's probably the largest part of the health workforce in any economy, and there are plenty of women on the health workforce as well, and many low-paid jobs. It's not just the doctors, you know, there are many people in the health workforce which are not very well paid. And actually we've had an intervention this morning, you know, from a colleague from Eurocarers, mentioning also the informal carers, which is probably even larger in numbers, of course. But I know that you have a policy which is straddling hospitals and primary care and also taken into account the sustainability. So please tell us a little bit about this policy, the intervention.
Thank you. It's quite true. In hospitals today, it's nursing who is doing the most part, and nurses. And nurses mostly are women. And decisions are not being made by the nurses or the women in the hospitals, mainly worldwide. In Norway, we are trying to refocus on how to make the profession more like gender equality-like. It's not easy because, you know, the decisions are made in boards, the decisions are made outside of the clinic, and inside the clinic, it's not the nurses who actually decide. It's not the women, but they do the work. And when it comes to cooperation between the hospitals and the primary care in Norway, we just had a commission, national commission, making a big report. I was in that commission. We made a white paper for the government. And what we're trying to do is to solve as many as possible of questions relating to health outside of hospitals. Because if we can keep, as a society, people outside of the health system, outside of hospitals, then we make politics for all. It's better economy to stay out of the health system. It's better economy to actually be not in need of persons like me. But in the end, how do we do that? We have to plan the society for how you actually can be sustainable on your own. How can you make it as long as you can, and then you need the specialized care when you have to have it. And when it comes to the gender equality, poverty has a gender. Let's talk about that. It's women who actually do not take decisions. It's women in the health systems as well who really becomes the low-paid persons you actually need when the doctors and the decisive people leave the building, and they get left there to more or less cope on their own.
So for me, two very clear messages. Number one, if gender equality is a societal goal, then start actually in the health system, because there's a lot of stuff to do. And the second is the very model of care has impacts on the sustainability of health system. That is what you said with this.
Yes, and please do not forget the NGOs. If people can rely on local society, it's even better.
Okay, so it's a thing about community, and it's about including civil society, both in decision making, but also in service delivery. And this is a little bit the link to what we heard in the morning on the informal carers. Wilfried, you've heard all this and probably said, yes, that's all true, but somebody has to pay the bill actually. How do we do this? How can we align this, please?
That's the point. There's no doubt about hospitals are contributing significantly to CO2 emissions. But to be honest, a green transformation for hospitals will cost a lot of money. And against that background, we have to query where comes the money from. And the hospitals, they don't have the money. In Germany, 60% of the hospitals have reported to be in the red. And on the other hand, we have more than 30 billion gap of investments in German hospitals. So the crucial question is, what can the hospitals really do, very concrete do, for fostering this green transformation? And my recommendation is that we focus on activity areas and measures that contribute to both, to reduce the carbon footprint and to save costs. And I have some examples for this. For example,
please give us some low-hanging fruits, things we should do first.
For example, the first point of the strategy I recommend is avoidance of waste. For example, 600 gram per bed per day, ready-to-use prepared food gets thrown into garbage every day, every bed for every patient. The second is, most of the hospitals do not repair the instruments. They throw it away. And we made a study on this pertaining scissors in the OR and saw blades. You can reduce the cost of use about 50%. Another example is medical remanufacturing. We analyzed the use of ablation catheters. An ablation catheter can cost 400 to 900 euro per piece. From industry, it's recommended to use it only one time. But it's possible to reuse it. If you reuse it 4 times, you can save a lot of money. You can reduce the cost per procedure from 800, in average, 800 euro to 400 euro. And these areas of interest we have to identify, and then we have to pick it up and say, let's do it. Here we have the opportunity to reduce cost and to contribute to CO2 reduction.
But it sounds like a huge task, because what I get from you is we need to look into the disposables individually, whether we can reuse them or whether we buy something which is reusable. And are we already starting with this task?
Yes, in our hospital we have already started with this, and I can say we have really made a good success on it. But there is more. We also have to look for cradle-to-cradle products, for example. In laundry, we have new materials now. You can use this material for clinical gownings and so on. You can use it 80 times, 80 times, and then you can, let's say, very pictured, you can throw it in the area and it will compost. This is a very ideal product, but the problem is, in the moment, you can buy it and you can use it, but it's 30% more expensive than the normal product you use day by day. And this is the problem. It costs a lot of money. And one way could be that politics gives pilot projects and support pilot projects by money in order to find out where these product areas really are and what the benefits are from using these products.
But it also means actually that we need a lot of new skills at hospitals and healthcare facilities, people who understand this, who understand the circular economy, who understand the economics, who understand, what can be used and what not. And that brings me to you, Catherine, because, Catherine, you're from France, from a very important school, which is literally training all hospital managers in France.
Indeed, we are training future and current hospital managers, initial for academic training and long life training. So, of course, we are involved in such transformation, and we bet that the hospital manager are very important in that transformation. But of course, as you have said, it's not the only one. But they are supposed, and they must have the skills to launch the transformations. And we have in Pulse a twofold orientation in our training program. First of all, we think that they have to launch a shift of mindset shift, a cultural shift. So through the management, they have to impulse that culture shift, that mindset shift. And on the second hand, we have to provide during our courses, our programs, tools in order that they are implementing very concrete actions. And they have to be convinced of the use of their actions, and they have to convince actors, for example, for medical disposal, to reuse them. They have to balance and to prove they can balance security, quality of care, and be running something more in a greener way, in a sustainable way. So for tools and for skills, to answer precisely to your questions, we have decided, we have made a decision, a choice, not to build, to design a specific program for greening hospital running, for transforming hospital in a more sustainable running, but to implement a greening point of view, greening tools in each skill we provide in running hospital. It's not greenwashing, you know, but it's to show that in each management skill, in each management field or hospital running field, we have to be involved in making hospital greener, making hospital sustainable. That's our point of view. So the skills, I come to the skills, if you don't mind. So for example, I just give some examples. In financial topics, we are putting the focus on how to build, how to design a greener budget, greener investment, more sustainable. In human resources, we are focusing on how to balance personal life, work life, to enhance care sharing, organize care sharing, support riding, collective sustainable transports, and that's not very expensive, and that works, and it doesn't cost a lot. And especially we are focusing on logistics, purchasing strategy, energy, of course, by choosing sustainable energy, and to optimize energy consumptions and materials, of course. And the training is focused on being efficient and concrete, adapt their running hospitals or in their daily function.
Catherine, I find this very encouraging. We are actually part of a EHMA-led project, Be Well, which is on digital and green skills, and together with NIVEL, the Dutch Health Systems Research Institute, we are researching these skills, and we are thinking about, you know, how do we get the skills into the system? And of course, one main way is institutions like your institute, you know, but also France is a little bit an outlier because that all hospital directors go through the same school you will not find in so many countries. So we need to find many ways how to bring these skills into it, but very, very concrete. Thank you so much. Scott, you heard all this after your presentation. Are you encouraged, or are you a little bit, do you find this quite daunting now?
What I've been thinking is that what's nice about this agenda is there's so many ways in. Like some of these, in a sense, are due to the way we do accounting. Right? What do you book as capital expenditure? What do you book as a given type of expenditure of revenue? So there's a bunch of ways in which costs are not fixed things like they might appear. It's about how you calculate and how you apply discount rates. That's just an example, you know. Accountants, seize your sword and your shield and come forth to save the planet, please. There's also a deeper point about financing, which is we've been having a debate about what to do about, for example, climate change for decades. And what the economists all say is that you should try to allocate costs. And that gives us carbon markets. And, you know, if you pick up a newspaper, there's really complicated stories about carbon markets and how car makers don't like them. There's another way, and it's politically much smarter, which is get technologies to scale by paying people to make them cheaper. Because a lot of these technologies cost more because they haven't scaled, because not enough of this stuff is being produced because there's not enough of a demand. How do you produce demand? You intervene with public policy to make people want reusable, compostable hospital gowns. Then it scales up and the price drops. Don't believe me? Look at solar panels right now. Don't believe me? Look at airplanes in the 1950s.
I can see smiles of all the colleagues from the industry in the audience and say, yes, God is right, man, yeah, let's scale up our technologies. Sandra, you were very beautifully describing the problems with circular economy and the drawbacks of COVID-19, talking about a lot of the barriers, but also what are the facilitators actually? How do you get this into your hospital now?
Okay, so first, like Scott, I'm a professor and I like to bring evidence. We've just had a manuscript published, it's open access, where we did a review of the applicability of current green practices in healthcare facilities. And you know what? Apart from what we've mentioned here with regard to waste management, energy, water, travel, transportation, hospital design, food optimization, green procurement and behavior, one finding of this review is that there is lack of awareness on the environmental impact by healthcare professionals. So
The skills question again.
So that is where we also need to focus. It's still abstract up there, Scott. And it starts frontline. So where should we go first and foremost as part of a project Safe Europe that I'm part of, dealing with radiographers and radiotherapists? Start at the curriculum. Are we even mentioning circular economy, which hits 3 SDGs? SDG 3, 7, and 13. Start from there and increase the awareness. You know what? The physician comes to the manager and says, my problem is taking care of this patient, and my problem is making sure that this patient gets better. But as Scott said, that is not the only thing that we should be focusing on, but systems thinking, again, not crisis management, because that we are experts in crisis management. Systems thinking. I am part of society. The way we work, the way we function, how are we separating waste? How are we using medication? How are we procuring? Is there green procurement, etc.? Is every healthcare professional aware of that?
But that's pretty much a culture change, as Catherine has said, and Wilfried have also alluded to it, isn't it?
So basically, facilitator number 1, start, catch them young. The curriculum. Start from the very early years of medical school, nursing school, healthcare professional schools, whatever, that you are not just focusing on that problem.
What do we do with the people like you and me, you know?
Pardon?
What do we do with the people like you and me that have left school for a while?
Okay. Well, we need what Scott said. We need a multi-sectoral approach. We need to get everybody on board.
Okay, good. Can I come over to you? And I mean, you were very clear about your statements on sustainability, models of care, and equity, and of course, a more gender equitable society is a policy goal in Norwegian. But how do we really get there? Is it too expensive? You were talking about the nurses, mostly female nurses, are not making the decisions, other people are making the decisions, you know, how do we get the change into the system?
We think that we don't have to provide everything into hospitals. What happens before a patient becomes a hospital patient? What happens is what is not taking place in the primary care. If we can treat people where they live, if we can have a sustainable chain of healthcare workers inside your local society, you take down the pressure on hospitals. But to do that, you need policies to have this chain of impacts. You have to decide that this is the way we want it. We do not want hospitals all over the place. You have to have politics to make decisions where to do what.
But you represent the nurses, it's like a trade union. So
Yeah.
how do you move forward, represent the interest of your group of people and combine this with sustainability?
Because what every single sector has to do to make success is listen to your people. And that's the beauty of trade unions. We do.
Yes, but how do you make sure that the others are listening to you?
By cooperating in the workforce, and that's the beauty of the Scandinavian countries. We have this system of collaboration between the government and the unions and hospitals,
So
deciders.
I get it from you that social partnership is key in this, and probably in the Scandinavian model, the social partnership is a little bit less confrontational as it is, for example, in France, or in Germany, or in Belgium.
We have another way of doing it, if I can put it that way. We mostly have many of the same questions, but we find solutions within the system. And that's probably the Scandinavian success model in our view. Yeah.
Wilfried, I could ask you so many questions, after what I heard here. So, but maybe, well, we start a little bit with, we continue with your implementation and your insights on this one, and also on the social partnership question,
The question was what drives change in the system, and this is a crucial question, I think. And my opinion is the precondition for a green transformation, a success in a green transformation, is an incentive system that drives and nudges the decision makers to green behavior, green decision making, and green strategies. And I think this we have to force, and we need the politicians for this. We can't do it. We can't do it alone.
Aren't we hopeless when it comes to incentives?
Not really. Not really, because all the aims of the EU, for example, are very sportive, and they are made by politicians. But we also need industry. We need industry, the innovation of the industry, and we need the readiness for offering green products in future. And therefore, I hope that more and more from industry side, products will be offered that are, I call it LPU, limited patient use products. Not single use in order to throw it away after having used it, but limited patient use. So you can be sure as a physician that you have the right instrument for the right patient.
So innovation will be one of the drivers. Innovation will be one of the drivers, but of course the technology itself will not be good enough. We also need to have a little bit the organizational change. We need to have the cultural change you were referring to. We need to have the skills change in this. So things are coming quite together. Catherine, can I come back to you?
Yeah. Well, I just give a very concrete example what we launch in our team. So in my health management department, we are around 50 teachers, but two kind of teachers. Teachers who are coming from hospitals, they are hospital managers teaching some very concrete skills, and researchers. And of course, we are secretaries and so on. So we decided that to deliver skills to run in a greener way, we must set an example. We must be exemplary for the trainees. So before providing skills to the future, we made a seminary devoted to how to green our teachings, our programs. And in a very simple way, we had a twofold aim. First of all, to enhance our team building, and second aim, to embrace the cultural change, the cultural shift, as you said. So we make something very simple. We launch a collective climate fresco applied on health sector. So we built this kind of fresco, collective one, applied about each decision making, each concrete actions we are doing, we are involving, we are launching in hospital. So we were very aware, we became very aware of the concrete actions and how we have to change our way of teaching to impulse a greener point of view.
So it's not only train the trainers, it's also if you propose cultural change to your organizations, you need to have this internally as well. Scott, can we have a couple of reflections for you on what was said and with regards to the drivers of change, because we've heard about incentives, we heard about cultures, we heard about training and skills, and the importance of social partnerships, actually, whether they are consensual or confrontational. But I think these are really very important things. Have we missed something, or?
I mean, I think incentives and culture are pretty strong drivers of human behavior, along with laziness. I want to pick up two things. One is something Torbjörn said. And in the international research, it is an answered question. Unions promote equality within their workforce. If you have a unionized company, it has less inequality. If you have enough union penetration across your society, you get less inequality. And here's the best thing. You don't need to assume that anybody is a nice person whatsoever. Because if a union responds to the workforce, then it has a structural incentive to be less discriminatory than the management. Right? So you don't have to have nice unions in any way, shape, or form, but they do reduce inequality. A lot of these goals, the most efficient way to get there is to empower the people who benefit from coming closer to them. So that's, I think, why fights over the roles of union are always so important. And trust me, my teaching assistants have been on strike for the last 6 months. It's frustrating, but I bite my tongue because I've read exactly that research. And the other point I'd make, because I think we've done a very good job thinking about incentives and these wonderful world of concrete interventions, right? When surgeons want a tool, don't get an entire pack of 20 things, which they so often do. Get one thing, and don't throw away the other 19 that didn't get used, Wilfred's point. But instead I'd say, look around. If we had had an EHMA in 1960, how many of you would have been in the room? Pretty small number, no? Economists try to estimate the welfare benefits, the economic benefits, the GDP benefits of increased equality, of allowing disabled people and women and people of all sorts of genders and reducing racism. It's absolutely immense. So I'll close with a story. There was once a guy named Byron White, an American, who had been accepted at Harvard Law School, but he missed his train in New York, and so he attended Yale Law School instead. He got bored after 2 of his 3 years of legal education, and he went and he played for a professional football team. He then came back, finished his law school, and ended up on the Supreme Court. This is an insane story in 2023, right? I mean, what would the equivalent be? I was going to the LSE, but I missed my Eurostar, so I got a degree from Sciences Po, but I got bored after a little while and spent some time playing for Real Madrid. Like, what? And what was the answer? The football and the scholarship are much better now because you have to compete. You can't do these as a hobby. We got lots more competition because of reduced discrimination, and we have an enormous economic benefit from not discriminating and from allowing everybody to do things to the best of their skill. And that's why you don't have anybody taking a hobby from elite education to play professional football, and you've got better education, you've got better football for it. We're already reaping the benefits. We need to continue.
Thank you so much, Scott. And this was very important for our co-benefits theme, which is the theme of this very plenary. And as a motto, we could say, you know, don't ask what other sectors can do for us, ask what health can do actually for other sectors. Now, thank you to our speakers, because due to your disciplined intervention, we have still enough time for questions and answers from the floor. And I hope that there are plenty, otherwise I have prepared a couple of questions, so I always wanted to ask them. But please, where are the first ones? Nathan, did you? There, yes. Sir, please, I'm coming to you. I'm coming.
I just want to
No, wait, I'm coming with a microphone. No, I don't give it to you.
Okay. I just want to make one comment in all of this, and it might sound very maybe pedantic if you want to put it that way, but it all comes down to the politics. It all comes down to the decision making. I like all what you said, but the decisions have to be made. So the big question, the $60 million question is, how do we get those who have assumed the corridors of decision making to make the decisions?
Can you introduce yourself?
Damian Grace from the Caribbean, Grenada, the island of Grenada.
Excellent, thank you. More questions, please, before we get back to our wonderful panelists. Oh, yes, I see a lot of hands. Yes.
I'll be quick. Steve Moore, I'm representing Saudi's health system. Really curious to ask Scott about any good examples. I feel very almost anxiety of what you guys have said today. And I don't know if you know about NEOM and what they're trying to achieve in NEOM, this new mega city in Saudi, starting from scratch. But I'm just wondering, where else? Where are the beacons of light in all of this?
Okay, thanks. So I saw here one more. Please introduce yourself.
Hello, Rustem from Albania, Associate Professor at Medical Sciences. So this question is actually for Professor Sandra. I appreciate the input that you said that the change should start from the curricula. Because so far as I know, I see that curricula hasn't changed much. So in medical school, medical doctors, of course, learn a little bit of basics, public health, but they don't learn much about management. As well, the same thing as the nurses. We do have mass, we have Bologna system, 3+2, and we teach them a lot of surgeries, pediatrics and lots of science, but we don't teach them in management, where in many countries the nurses take place of the role of management. So what help can we have from EHMA? For example, I'm from Albania, to have these changes through the open lectures or to have a change step by step. Thank you.
That sounds like a request for a European curricula on green skills, and Emma has something to offer for you on this. More questions, please.
Thank you. Hi, it's Nabil Jamshid from UK. Two things. First, a challenge, and then a question, if I may. The challenge, Scott, you were talking about inequalities and how that could be addressed using some of what you were explaining from SDGs and all the rest of it. The problem is that we know that culture eats a strategy for breakfast, which I'd had a really lovely breakfast this morning. The problem lies in that is when we are thinking about changing cultures, where we're thinking about different ideas, we talk about innovation, but we forget there is a very deep deprivation of digital enablement in the communities that we serve. And when we look at that deprivation versus inequalities that generates, it's a big, significant gap. So something else or something different needs to be done, not only thinking about digital as a solution. The question I have is, when we are thinking about green planet, when we are thinking about the greenery, and Prof. Wilfred was talking about, how do we get around this? What is the solution? Perhaps the solution is when we as hospital settings or providers of healthcare services, as managers, policy makers, are developing organizations through their governance models. We know FTSE 100 and 250s are obliged to comply with the governance regulations on ESG standards. Perhaps it's time to put the onus back on them to invest in the hospital settings, have a regulatory body that allows us to invest and reinvest, work alongside investment banks who put some money aside to enable the greener, better care for our future generations. Is that not right?
Great question, thank you so much. I think we can still take two. Here's one, and over there a second.
Yes, hi, thank you all. So I'm Manos Chesotis. I'm a research project manager working for Altems here in Rome. Thank you for all your wonderful perspectives from the policymaker, from the healthcare professionals, from training, from the funding point of view. My question is that in terms of the sustainability development goals that basically, as Scott Greer said, they're created to objectively improve our life on this planet. How do you see in this transformation, in this cultural change that you've all been talking, how do we see the role and the involvement of the patients, of the citizens in all this culture transformation?
Citizens, yeah, thank you. Citizens and civil society, great. Please.
Okay, so I'm the last one. Barbara Gösenbauer, representing Austria here. My question would be, as a socioeconomist and also somebody who's really interested in circular economy, what you were talking about, there's actually an R missing from circular economy, and that would be the refuse R. And I think the refuse R could potentially be achieved by focusing a lot on prevention. And I think we all talked about a lot of, having people in the hospital and how to get the hospital screener, but wouldn't it be more effective to just focus like a lot on prevention to, for example, have not that much of cardiovascular diseases in a hospital that we have to react to, but prevent them. So, for example, in a way also of cultural change, wouldn't it be better to like focus on prevention measures that also have, like, for example, in exercise, if you have the social bond, for example, that you actually want to produce, and do that via an exercise challenge or something like that for older people, for example.
Thank you so much. I think your point is well taken. It's again about the question of the influence of the model of care on sustainability, actually. Please, I hope you remember all the questions very, very correctly, because there were so many very important questions. Sandra, shall we start with you? Yes, take it from Scott. Of course.
Okay. So, is it on?
It's on.
Okay.
Just talk about green button. It's always on your nose, on the flat side.
This?
Yeah. I'll give you mine and you.
Okay. That's fine. So I hope I remember all the questions, and I hope I heard everything. But starting with the contribution of EHMA at the moment, because as president, I want to capitalize on that. And I know there is George at the back, and I hope he's listening. And indeed, I am privileged also to have on the floor Professor Anne Mahon, who's done a brilliant job as director of the Program Directors Group. So what we have been doing this year under the leadership of Anne is that we are the program directors of the health management curriculum, and we are doing our best to include all the relevant topics and the timely topics that should come into the curriculum, but not only in the health management courses, but how we can also service other courses. And starting with myself, what I'm doing is that even though I'm head of the Department of Health Systems Management and Leadership, I've had discussions with every head of department and asking them, if I had to give you more and service you, these are the topics that need to be done. So I think each and every one of us can do a great deal. In order to achieve it at European level, EHMA is a very important player, because EHMA is being recognized by the European Commission, is being recognized by the Association of Universities, being recognized. So as a body, yes, that is very important. Systems thinking. The important thing is we need to get people, it was a breath of fresh air to have this morning the dean of the medical school talking about not physicians just taking care of the patients, but getting a systems thinking, getting skills other than that. I believe as well, I want to answer the culture change. Again, I refer, we can do everything. And every individual has a role in society. So there are people who can do the prevention side, the exercise side, but it all falls under systems thinking. And I keep on saying this, systems thinking. Everybody has a place in systems thinking. We need to put out the fire, which is crisis management, but don't stop there. Let's take it to the systems level. People in prevention, people in green economy, everybody coming together, multi-sectorally, and what can we give to society?
Thanks, Sandra. Over to you, Torbjörn. So you heard a lot of questions coming from the floor. Probably one or two were directed towards you.
Well, I heard the gentleman from Grenada, and he asked the $60 million question. That's too small an amount, sir. The thing is, well-being should be for all, not just the people who can pay by their own pocket. And that's why we have to have a society making decisions for everyone. That's why we need policies in this matter. That's why this question is international. In Europe, both for the European Union and for all, we need governments stepping up. Thank you.
I totally agree that's not the 60 million, but the $60 billion question. But at the same time, you know, if we don't have done our homework and we have the interventions, we have the numbers, we have the models, you know, which we can apply, why should policymakers react to it? Actually, they wouldn't. So I think politics is super, super important, and we have not so much influence on it, but we need to be prepared for this and do our homework. Wilfried, back to you again.
Yes, we talked about a lot of cultural change here, also in the audience, and I think cultural change doesn't fall from heaven. We have to work it out. That means we need an incentive system that drives cultural change, and this incentive system may be the result of, let's call it, an orchestrated initiative. That means we need several players on board, and they have to play their role. We need, as I said, the industry, we need the politicians, we need the hospital representatives, and we need other players.
And from your experience from Germany, do you have the impression they are coming together, there's convergence, these different players?
Not yet, because to be honest, the interests are too different. When you talk to the guys from industry, they say, we want to make money, we have to pay for our investors and so on. If you talk to the hospital decision makers, the hospital guys, they tell me, we don't have the money for this, we feel to be alone in the corner, the politicians don't do anything for us, and so on and so on. And that's a special additional problem in Germany. We have the sickness funds. They also are powerful initiatives, and we also have to cope with them. No, it's really difficult, really.
No, we need to finish somehow on a positive note. Catherine and then Scott, but both very briefly.
No question about training.
There was no question for you?
No, I just want to answer about training physicians with management. We have launched such programs because we think that doctors are crucial in the management in the wards, and they have no training about that, of course, during their academic training. So we meet great success with those programs because doctors are very eager to be trained in management. I mean, doctors, you know, ward manager or more, because in France we have a dynamic of trust hospital, of designing trust hospitals. So they need to be more skilled in management field. And they like to be more trained in that field because they want to have effective, true debates with hospital managers. And they feel weak in running hospital debates because they don't have the key skills. And we have a great success. If you want, I can explain what we are doing, where we are training.
Sounds great, Catherine.
Yeah,
wonderful.
and it's diploma. It's yeah.
Great, Scott, please. Very briefly.
Okay, 3 points. 1, culture. That phrase, culture eats strategy for breakfast, that's perfect top-down management kind of thinking, right? It's no accident that it came from an investor. What I'd throw back is, what is the culture? Because people don't come only as newly trained medics, let alone only as newly hired security guards or porters.
So getting aligned with broader cultural changes and being thoughtful about that is a way to get a lot done. Politics, of course, I'm a political scientist. But on one hand, the ideas in politics come from somewhere, and they come from people who are credible and can explain why they're a good idea. It's not for fun that we're doing a whole lot of modeling and econometrics on these policies. But also, there's always something you can do. My Spanish example of the Green Hospital, the guys who did that went into hospital management because their previous career as Catalan secessionist politicians had led to them being thrown in jail. These are literally ex-political prisoners who have found a new way to make a difference. And third, prevention. And I think this also speaks to the Saudi point, which is prevention's great. I think everybody should have bicycled here. You're all here, so most of you clearly didn't bicycle here. But in health systems, we're throwing around, what, 10% of GDP? You want to reduce respiratory diseases? There's a lot of ways our incinerators and our planning can do that. You want to increase physical activity? There's a lot of ways that our buildings and our locations can do that. You want to decrease inflammation and general weathering? There's a lot of ways that our labor relations can do that. So we can do a lot of prevention, and that has the compelling advantage that it's not saying tear down the hospital, it's saying use it better.
Scott, thank you so much for this, and thank you to all our excellent speakers and panelists. I think they really deserve a large applause. And now I would like to invite Americo. Don't go. Don't. I would like to invite Americo to close the session. Americo, please.
Thank you. Actually, very, very interesting session. Thank you, Matthias, for conducting, so brilliantly this session. Really, I've heard very interesting things, and I fully agree with all of you regarding the importance of culture, the idea of bringing in the curriculum, this issue very, very strongly. But I think that an important word has been pronounced by Wilfred: incentives. Incentives and politics and politicians. Because what I've heard here is that what all health economists have said to the policymakers in the past probably is not so relevant anymore. We told them, please consider that we need a specific amount of money to be dedicated to healthcare, to maintain sustainability of the system and so on. Now what you're saying is that a matter of quality of spending. And the quality of spending, where quality is not just the kind of technology, the kind of hospital and so on, but is a different quality spending. Scott Greer made the example of the hospital, and probably we now should suggest to politicians to revise completely the accreditation mechanisms, the accreditation criteria, to create incentives to make, hospital greener than in the past. And second, incentive probably should be given to the industry. And so this is the occasion to launch the next plenary session tomorrow, because now we are conducting a research. There is there Michela Bobini, that is a PhD student here, that is studying the implementation of the assessment of the environmental impact of health technologies within HTA frameworks. And what is coming out is that, there is a lot to do. I mean, at the moment, when we are selecting health technologies, when we are investing in new health technologies, the number of issues and questions that we are answering regarding the environmental implications of health technologies are 2 out of 200 questions that are the typical framework of the core model of EUNETA. So I think that we have a lot of work to do. That, of course, deals with the culture, deals with the involvement of clinicians, nursing, and so on. But there is a lot to do to incentivize the players of the system, the owners of the hospitals, public, private, and the industry, to guarantee through their supply something that can give us the environmental sustainability of the system. So thank you very much, because for me it was really, really a great panel. Thanks.